My name is Nicholas Verne, and I'd like to welcome you to this evening's ANMS Virtual Symposia. So before we get started, I'd like to share with you a couple of announcements. Our next ANMS Virtual Symposium will be on December 14th on Pearls of Wisdom, Colonic Manometry. Nominations are also now being accepted for the ANMS Distinguished Investigator Award for Women in Neurogastroenterology through December 16th. Registration is also now open for the ANMS hands-on workshop on Saturday, February 25th in Redwood City, California. And a reminder of our ANMS annual meeting, which will be held next year, August 11th through the 13th, 2023 in Austin, Texas. Please note that the abstract deadline will be March 8th, 2023. So our clinical virtual symposium this evening is entitled The Doctor-Patient Relationship in Treating Gastroparesis. Our moderators are Dr. Baha Moshiree and Emily Haller. A little bit about our moderators. Dr. Moshiree is Clinical Professor of Medicine, Wake Forest Medical University, and Director of Motility in the Division of Gastroenterology at Atrium Health in Charlotte, North Carolina. She trained at the University of Florida for combined undergraduate and medical school, and later gastroenterology fellowship with a focus on functional bowel diseases and motility disorders. Her expertise and interests are in the diagnosis and management of patients with chronic gastrointestinal illnesses such as gastroparesis, irritable bowel syndrome, and constipation with pelvic floor disorders. She's participated in several multinational studies in both IBS and gastroparesis, and is part of the international consensus guidelines for gastroparesis. Ms. Haller is an expert in digestive health and medical nutrition therapy for gastrointestinal disease. Emily is the lead GI dietitian at the Division of Gastroenterology and Hepatology at the University of Michigan Health, Michigan Medicine, where she provides individual nutrition counseling to patients with a variety of GI conditions. So with that, I'll turn this evening's program over to Dr. Moshiree and Ms. Haller.
Thank you so much, Nick. I'm excited to present this segment and have both Dr. Ken Koch and Laura Dotson on this call. Laura Dotson, she's a native of North Carolina. She's the patient perspective in this venue. She's a practicing interior designer and educator. She graduated from Salem College and the University of North Carolina at Greensboro. And she also graduated from Prince of Wales Institute of Architecture. She did graduate work at North Carolina University of Agriculture in addition, and also Technical University. She was referred to Dr. Koch after being diagnosed with severe gastroparesis symptoms, and she's now much better, but I'll let her tell us that. And she'd love to share her experience with us, and I'm really excited to hear her speak.
Thank you, Baha. I'm very excited to be here. And the patient perspective obviously is a huge part of the relationship. And might I say, it's not a partnership, but it is a relationship. It's a relationship that lasts a long time, as mine has with Dr. Koch for 17 years. To tell my story, in 2004, I had my gallbladder removed. And immediately thereafter, I just anything I ate would not move forward. It would come back through vomiting 4 to 5 hours later. And, you know, I went back to my surgeon and I said, I'm still throwing up. And he said, what do you mean still? And he sent me back to the gastroenterologist who had done an ERCP on me to clean out that common duct. And I just was so frustrated because the diagnosis kept being acid reflux. Yeah, I'm sure I had some acid reflux, of course. But I also knew through my body wisdom that there was something more going on, because when I would vomit, it was what I had eaten 4 or 5 hours earlier, and nothing had happened to it except me chewing. So I mean, you know, we know enough to know that's really peculiar, and that something else beside acid reflux is causing that. And I went back to him, back and back and back, trying to get some resolution or information about what I could do to heal myself. And that didn't work out with this particular gastroenterologist. So at the time, I was working for a company which is now a part of Quest Diagnostics. And I had a client who is a wonderful listener. She listened to me. And she said, yeah, come on in. I think I know what you have. And I made an appointment, got in, and she said, yeah, we need to do the gastric emptying test. And we did that. And it was very evident that there was no motility. I mean, there was no movement at all. And she said, there is a new guy at Wake Forest University, and I live in Greensboro, North Carolina, so that's in proximity. But I would have gone anywhere. I was so desperate. I was so just completely devastated in my livelihood, in my hope of what in the world is going on with me. I was going to work every day, and I was vomiting in the ladies' room. Well, what were they thinking? They were thinking, of course, that I had an eating disorder. I knew I didn't have an eating disorder per se, but I had something wrong with my gastrointestinal system. So when she sent me to Wake Forest Baptist, now Atrium Health, she sent me to my Dr. Koch. And the first words that after in that first visit, he said verbatim, and it was so life-changing to me that I will never forget his words. His words were, yes, Laura, you have gastroparesis, and there's no cure for this, but I'm going to be right here with you, and I am going to make sure you're as comfortable as I possibly can. And there's new stuff coming along all the time. 17 years later, he's still with me. That to me is not just a partnership, a doctor-patient partnership. It's a relationship. A partnership is something that's transactional. A relationship is something that both take efforts to understand each other. And we did that. And we've done that successfully. And we both, I'll speak for him too, enjoy sharing what it can be like between a patient who is so desperate and dying literally in front in this wealthy country of ours, dying, starving to death per se. And it can happen. It can happen. It can happen through each of you and with each of you. If you're a patient, there's hope. There's hope. And Dr. Koch will share with you his diet that he has researched and he gave to me. When he gave that dietary plan and approach to me. Not only did he deliver hope to me, but we had a plan. We had a plan. And when he gave me that plan, you know, the first one is to make sure you're hydrated, because dehydration is serious. We as a society don't take that very seriously, but it is very serious. And I drank chicken broth from the back seat of my car from the can. I drank Gatorade from the jar. It depended. When I was maintaining my work, and I would either left or right, depending on what I wanted to try at that point. And I got through, and the hope is real. The hope is real. I'm living, breathing proof that it's real. I don't have gastroparesis anymore. And if you're a patient or you're a doctor, please know that there is hope. And if you are a physician that works with patients with this, please know that your words matter. Your words matter so much. What Dr. Koch said to me was the definitive delivery of hope. If your patient has hope, then it's going to be successful. Whatever the outcome, it doesn't matter if they're well like I am, no gastroparesis, or if they're marginally well at times. Your words matter. And it's just so important. And it still moves me to this day. Dr. Koch's words resonate in my mind all the time. And I know you understand that. I know you do. And I know you're busy, and I know you're rushed. I get all that, but your words really do matter. And I thank you for this opportunity to be heard as a patient representative and an advocate for those who suffer so much. And they suffer in silence because when they leave you, if you're a doctor or patients who are listening, you know that everything in our world revolves around food.
Laura, did you get muted? Sorry, I'm having trouble hearing you.
Sorry for that interruption.
No, it's okay. We can hear you now. Thank you.
Thank you. I didn't do anything. I don't know what that glitch was.
It was just a few seconds. Yeah. Thank you.
Yeah. Thank you. If your words matter, and there is always hope, because I healed naturally, and Dr. Koch was so supportive of that. And everybody deserves a Dr. Koch like I've had. And the number one thing that he did for me initially is he listened to me. He listened. Please listen. Thank you.
Thank you, Laura. Thank you so much for sharing your story. Your story in itself and just your message of hope is so powerful. And I know many patients are going to be able to relate to that. So now I have the pleasure of introducing Dr. Kenneth Koch. He is a professor of medicine in the section on gastroenterology and hepatology at Wake Forest University's School of Medicine and Atrium Health Wake Forest Baptist. He has a career-long interest in the electrical activity of the gastrointestinal tract, especially the pacemaker system that controls stomach neuromuscular function. He has published over 175 scientific papers, written 3 books, and contributed to over 40 book chapters. His dedication continues as he investigates the causes of nausea and vomiting and seeks specific diet, drug, and device treatments for patients suffering from neuromuscular diseases and disorders of the gastrointestinal tract.
Good evening, everybody, and thank you for tuning in. And of course, I have to say hello to Laura, who was part of this doctor-patient relationship. And, you know, every patient we meet in the office is where we start to have doctor-patient relationships. And so in this few minutes, I'm going to mix in some of the ways that I try to establish a healthy, hopeful relationship, things I never write about. And then I'm going to mix in some things I do write about, like how the stomach works and some things that the patient can be thinking of, as well as the doctor. So if you have 2 informed people talking about a problem, you should get to a solution. So let's see where these slides take us. And as we talk about this working relationship in the doctor's office, can I have the next slide, please? And Stephanie, appreciate that. So the gastroenterologist and the patient meet. And we're talking about like the first meeting. And back when I was a medical student, we talked a lot about rapport. And I hope it's still talked about. I'm not with too many first-year medical students, second years. But what is rapport? It's a harmonious relationship where each person understands the other's feelings and ideas. So I certainly try to learn that from the patient. But as the relationship goes on, I certainly share my feelings. I get frustrated. I have ideas of the diagnosis we should be pursuing. And maybe the patient isn't so keen on that test or has to think about it. But we're always working towards a harmonious relationship, not acrimonious, harmonious. And I do very simple things. I mean, I'm very important to introduce myself. The accompanying person is obviously a very important person to that patient. I always say, and who do you have here today? Or who is this? So we get to some very personal things, but they're general things. You know, where do you live? What are your occupation? Maybe get to family. You see, these are things that take 2 minutes, but they establish, to me, their basic courtesies. And I begin to understand who the patient is in the context of where they are on Earth. Are they an executive, a factory worker, a medical person? And this helps me listen in a special way, perhaps, and orients me for later questioning, how I might pose questions and so on. Then I've always been interested in the word hospitality. Well, the real definition is the friendly, generous reception and entertainment of guests, visitors, and strangers. But wait a minute, don't we work in hospitals? Should a hospital be a place of hospitality? You know it when you see it. We often work in hospital-based clinics. And so I like to be a host. I'd like to be hospitable so the patient is not a stranger. They're a patient. They're a very special person, right? They've come with a problem and we have the honor to try to figure it out. So we try to get on the same page. We try to establish that rapport so we can understand, like Laura said, so we can understand words. But first you have to listen to hear the words. So let's talk, go to the next slide, please. And here are some of the words that we toss around. I have gastroparesis. Well, gastroparesis is the delayed emptying of a test meal in the absence of mechanical obstruction of the stomach. Well, you can quantify that. I mean, you can get a number. I have 25% of my meal left in 4 hours, and therefore somebody gave me the diagnosis of gastroparesis. It's pretty specific. But look at the symptoms that we associate with gastroparesis, that early satiety, fullness, the god-awful nausea that can knock you down, vomiting, nobody wants to vomit. We change our diet. We do anything we can do to stop vomiting. We don't vomit. Bloating, distension, abdominal discomfort, pain. I mean, those are the symptoms we wrap around gastroparesis, but there's a big problem. Those symptoms in general, do not correlate very well with the rate of gastric emptying. And part of the reason is they are, they're also very general. They're not specific. A lot of different GI problems can cause those symptoms. So even in a patient who has gastroparesis, I'm wondering, could there be something else? Because the other symptoms in the GI system can cause those symptoms. Other diseases can cause those symptoms. Next slide, please. And so the problem is, as you go through and see doctors, as Laura did, and somebody thinks it's the gallbladder comes out, you're not better, maybe worse, like Laura was. Drugs aren't helping. People can't find anything on exam. You get to gastros, we do the upper endoscopy. We love to do upper endoscopies. We love to do colonoscopies, and they're normal. They look at the lining. They look at the skin, the superficial skin. They don't look at function or contractions or relaxations. Maybe you've heard your gallbladder is normal. Let's get a CT scan, normal. CT of the head, normal. Labs, normal. I suspect some patients out there have gone through that. And a lot of us doctors, this is what we do because we're looking for a structural problem, something that we can point at and say, that's the obstruction, that's the lesion, that's the ulcer. And in the realm of neurogastroenterology, you see those tests are often very normal. There's some minimal problem, doesn't seem to explain the symptoms. And so the symptoms continue. The patient is certainly frustrated. The family's getting very nervous and anxious about why you're not getting better. Why can't anybody find the problem? And if you're the doctor in the middle of all this, it's getting very frustrating. What do we do? And this is this area that we kind of call neuromuscular problems, motility problems of the gastrointestinal tract. So the next slide. So I often get patients referred who've seen many doctors, and as a doctor, I say, gee, what am I going to come up with? What will I have to offer? And really over the years, I've seen patients, things come to mind. And that's why you have to be, your doctor should be an active listener. So you listen and you listen some more, because in the end, you ought to be driven, the doctor should be driven to get to the bottom of the case. I often say, do you like to watch Law and Order? We have to get the perpetrator. We have to find the perpetrator, what is driving your symptoms. So we listen to the story, but I've had patients who say, I've had this for 5 years. Shall I start 5 years ago? Well, guess what? You can't go through 5 years of symptoms. It's just, you don't have time. And so I often say, well, let's just go through a medium bad day, like from a week ago, a bad day in the past month, whatever. I'll control the clock. And so how do you feel when you wake up in the morning? And it can lay out a lot of symptoms in the course of a day. How are they feeling by noon? Mid-afternoon? What are they eating? Does it help the nausea, hurt the nausea? What stimulates the pain? What relieves the pain? And by doing that, you can encapsulate what that patient's life is like by that typical bad day. And so when I kind of get that story, often there's 6 symptoms. And I'll say, I heard what you say, but here's the deal. What symptom is number 1? What symptom is number 1? Let's start with that one. And, you know, because if I can help that number one symptom, maybe the others, you know, we can get to, they'll fall into place. And I say, okay, you can have two symptoms, but with a simple brain, I just want to understand what bothers you the most. And that's where we start. And then around that symptom, I'll cross-examine, try to understand the nature of the pain and some of those things I just mentioned. And, you know, as you're doing that, guess what? You're building rapport, you're showing you're interested. You want to find the problem's source. And of course, a patient who's worried, maybe they came in hostile or anxious, their story is being told and it's being heard actively. And over again, as I hear the story, I go, wait a minute, that doesn't sound so much like the stomach, sounds more like an esophageal problem. Or wait a minute, that pain sounds like it could be coming from an old scar. And so I never accept the diagnosis as gastroparesis. You know, if that was the total diagnosis, I hope somebody would have done something for it. So I'm always looking for more causes, if you will. And I've always liked this quote from Sir William Osler, father of internal medicine, who said, listen to your patient. He or she is telling you the diagnosis, The patient might not know the medical term for the diagnosis, but they speak, as Laura said, what their body is telling them to say. So this is very, very key. And from that, I build my differential diagnosis. Next slide. There we have to talk about the stomach. And just for the doctors know this, the doctors are supposed to know this, neurogastroenterologists know this, but I think when we talk about gastroparesis, you need to know how the stomach works when it's normal. When it's working normal, you say, I feel great after I eat. That was delicious. I think there's room for dessert. Well, the reason you feel great is because this wonderful organ is working, it's purring along like a Mercedes, okay? When you swallow, the fundus relaxes. The stomach's comfortably relaxing to receive the food. The corpus you can see there, it's where there's filling and it's mixing. It's gentle mixing, by the way, extremely gentle. You don't feel it slogging around. It's purring along, milling the food from big particles to those tiny particles, which then are gently ejected, if you will, into the duodenum through the pylorus. It is, the old timers called it antral systole. It's almost like a cardiac cycle, but there's emptying of that milled food and life is good. It's purring along and I'm comfortably full. The next slide. It can do all that work because it's paced. It is paced as carefully as the heart is paced. And this just shows these electrical rhythms called slow waves or pace setter potentials. And we know in a lot of gastroparetics now, especially diabetes and idiopathic gastroparesis, those pacemaker waves are depleted. Those are driven by special cells, the interstitial cells of Koch. They're the pacemaker cells. And as they drop out, you get less rhythm, you get less efficient contractions, you get nausea, fullness, and a lot of the symptoms that we've been talking about. So it's a very sophisticated organ, and when it works well, life is good. Next slide. But Dr. Koch, that's nice to know, but when I eat, I feel nauseous, I feel discomfort, I'm full, I might vomit chewed food, as Laura told us, and certainly you better be listening to that if you were doing a clinical visit. So here's the deal. Everything I just told you about the normal stomach, we know can go wrong and does go wrong in gastroparesis. The fundus doesn't relax. You have a weak 3-cycle per minute rhythm, or you have dysrhythmias racing throughout the antrum and the corpus. The antrum doesn't get strong. It's weak when it tries to move food out. The pylorus can be in spasm. The neurons are saying, we have a problem down here. Things are just out of whack. And this is a series of gastric neuromuscular problems that can afflict the patient, who in the end has that slow emptying of the test meal. Next slide. So we're back to how I'm thinking about, well, is that the problem? Is that stomach the main problem? The symptoms are pretty non-specific. Nausea, vomiting, discomfort sounds like it could be a lot of things. So I like to think outside the box, the stomach perhaps. But here's the deal: esophagus. Is this really a problem of atypical reflux? I just mentioned some subtle stomach problems. Gallbladder, is it stones or an emptying problem? Small bowel, could there be bacterial overgrowth? Colon, is this irritable bowel faking me out? These are both things. Patient has both gallbladder and delayed emptying. Is it a vascular problem? Hormonal problems? There are many ways to get to the symptoms of gastroparesis, which I reviewed. And so you have to think about those. If you just think gastroparesis, well, you're done thinking and you may have missed something. I had a patient once, I thought you'd like this. Took her a while to get to see me, but nobody had been able to figure out her nausea. And she finally said, you know, I guess I'm not a textbook case, but I think I've only been seeing textbook doctors. I've only been seeing textbook doctors. See, doctors are supposed to, you know, we read the textbooks, of course, but then we're supposed to be thinking and synthesizing and coming up with pathophysiological explanations for symptoms that may not be perfectly textbook. Next slide. So there are some tests, you know, to look at delayed emptying, the egg beaters test, it's a sandwich. And the thing is, it has to be done right. Even if they use the right meal, patient's supposed to stand for a minute each hour to get the actual scan. Some are actually done wrong, where the patient is lying on their back for 4 hours, can give you an abnormal result. There's a wireless capsule, motility capsule can measure transit time, but it has to be taken with the proper meal, and it has to be done according to you know, the standard protocol. Can't cut corners. You can measure the electrical rhythm with the electrogastrography. You can measure the pylorus now with an endoflip during endoscopy. So we can learn a lot about the pathophysiology now of a stomach in a patient with recurrent nausea and vomiting. Next slide. So we've taken the history, I put my thinking cap on, and I write down like esophagus, acid, heartburn, or I'll put down stomach, nausea, small bowel bloating. You know, I try to put down the organs that I think are misbehaving and link a symptom with it. And that's my hypothesis. I think your problem could actually be small bowel bacterial overgrowth. Maybe it's not just your stomach. And so we need to do a breath test. I schedule these tests. There could be 4 or 5. And I said, we'll do a follow-up visit when the tests are completed, and we'll re-talk about your symptoms, and let's see if a test abnormality can be lined up. So I do a lot of follow-up. I once had a doctor just say this simple thing: good medicine is follow-up. Because you have to follow up, or you don't know what you did had any effect. And there's how the relationship should build in a harmonious way. And sorry, this test didn't work out. This test gives us an opportunity. Maybe this will be the answer, you see? And so also at that first visit, I try to offer some initial treatment, something. Person may have driven away, person is still sick, and we've just been talking. And that's where we have so few drugs that work in gastroparesis and nausea, that I do spend quite a bit of time about a diet. If I think the stomach's really not working, you can't put regular food in a stomach that doesn't work. It really does have to be a lighter type diet. I'll talk about in a minute. We put it into 3 steps. Also, there might be some simple things I can adjust. Maybe the acid suppressing drug is really low dose, and I raise the dose. It's not rocket science, but I'm doing something to begin treatment that makes sense. So, this gives also a patient a chance to say, he's got some ideas, and, maybe this will work until we find a better answer for me or a better treatment. Next slide. So many patients have asked, what should I eat when I'm nauseated, when I'm vomiting? And so over the years, I've listened to many patients, and they tell me what they eat because they don't want to vomit. They begin to alter their diet so they don't vomit. And as it turns out, of course, the body has a lot of wisdom. Laura mentioned that. And so they say, well, here's what stays down. And liquids stay down better than solids. But, liquids are easier for the work of the stomach. The stomach doesn't have to work as hard to empty a liquid as it has to do much more milling and grinding, if you will, before it empties a solid. So there's one point. Starches are mixed and emptied easier than proteins. Mashed potatoes, easier than a hamburger. Proteins are mixed and emptied easier than fats. So that burger is easier to empty than a very fatty pork chop or something else, a fried chicken with lots of fat will be harder to empty than a protein. And then the hardest to empty for the stomach, thinking of the stomach as a workhorse, a very gentle workhorse, fresh vegetables, roughage, those textures are very hard for a weak stomach to mix and empty. And the next slide shows then, kind of based on this, a 3-step diet where the first step is just about hydration. Patients know this, but I go over it. I say, small amounts of liquids, electrolyte drinks, a gummy multivitamin, requires very little trituration. That's the fancy word for milling and emptying. If they can get in 30 ounces a day, they really should avoid dehydration. Step 2, soups and smoothies. This is the liquid nutrition. But maybe they'll tolerate a little cracker, a little caramel. They can choose something that tastes good in the stomach, not much work for a caramel. 6 little meals a day. This is not a complete diet. This is a diet to get you through nausea and vomiting. But the soups and smoothies, don't require so much of the milling and work of trituration. Maybe we can get up to 1,000 calories, 1,500 calories. Some people have milk, they can't tolerate milk or dairy. You got to take those out, but those are all obviously nice sources of liquid nutrition. Well, people want to chew, they want to enjoy food that's more solid, but it's the starches, chicken and fish, that would be the easiest. So mashed potatoes is the poster child. Wow, pretty easy to mash those up, and the stomach doesn't have much problem with them. Rice, small bits of chicken. And again, it takes more work for the stomach, but the stomach, the neuromuscularly challenged the stomach with these various issues may vary during the day or even during the week. And patients learn to go up and down on this scale of 1 to 3, depending how they feel. So here we have to perhaps avoid some fatty foods, red meats, those fresh vegetables, really hard for the stomach, and we substitute vitamins and other ways to get there. So we spend some time on this diet too, to get them, through the next weeks and months of their workup. Next slide. So we wrap up that visit then. I ask if patients had any pressing questions. Did I answer most of their questions? I say, you can call my office. The nurse will take messages and let us know if you have questions. So by the end of the visit, I've tried to establish a rapport, present a clear differential diagnosis based on organs, a test plan to say, is it this, is it that? Can we scratch something off? Did we find something that wasn't found before? And some thoughts where we might go with treatment, but most of those ideas have to wait till I have more data. And so that the patient with gastroparesis or unexplained symptoms and other diagnoses, as they leave, there's a plan, and we can hope together for better days ahead. Thank you.
Well, thank you both so much. This has been really fantastic, really informative. And thank you for providing actually really direct messages here in terms of the diet. I know Emily is salivating back there, literally with the recommendations that you've given. I guess I'm gonna ask the audience who are with us today. I know they've been really enjoying this. Please feel free to ask questions here because you have both the patient and the physician on this module. So this is like the perfect circumstance. But I'm just gonna start with a question for Laura. So I love the words you used. You said words matter. Definitive delivery of hope is important. And so I want to ask you, as a physician, we sometimes feel really uncomfortable if we can't do a definitive diagnosis, but that's not what you said. You said definitive delivery of hope. So tell me a little bit about that. You know, when did you feel like the diagnosis made was correct? And then did you need to hear that on the first appointment or not?
Well, my situation went 18 months out that I didn't have a resolution. And that yeah, my hope went from, you know, not understanding that it wasn't short term to just not having an answer. And I saw Dr. Koch, and his delivery of hope in that message that he gave me was everything. It was everything, because and it never occurred to me that I was going to have it for the rest of my life. It never occurred to me because of the words he chose. And I hope that lets patients and doctors know that, yeah, words are important. You know, yeah, and you can't just think that everybody knows your lingo. Your lingo, I'm an interior designer. My lingo is different than my clients. So as a doctor, I know it's full of Latin and all, you know, kinds of words, but make sure you transfer that in an understandable way to that particular patient. And it was beautiful. Thank you.
Yeah, thank you. And then Ken, on your side of the street, you know, we're always taught by Rome to make a definitive diagnosis and give assurances to our patients with confidence, right? So we're taught that all the time with regards to not motility disorders, but functional bowel diseases. So I guess, how do you deliver hope, and then at the same time know that there's still stuff that you need to, I guess, diagnose, and with diagnostic tests that you definitely have in your armamentarium, and provide that to a patient like a gastroparic patient?
Yeah, that's a good point, because I say right on that first visit, I'm not sure exactly what your symptoms are coming from. At that first visit, I really am looking for the perpetrator. I need to collect facts, and the patient has the best facts. You know, the patient is the source. That's the eyewitness. And I start talking law and order type lingo. You know, I need to collect the facts. We might have to do some ballistics. We might have to check for. I have to go back to the scene of the accident or the crime. And so that's when I order the test. So when I'll say, you know, I'm not sure where we're going with this yet, but by process of hypothesis, test, results, that second visit is actually the important one, because the test will be done. I re-examine the witness, if you will. I want to hear what the symptoms are. And now you see, I know the test results and the patient might not know the test results. And I'm recalibrating what my thought process is. And maybe on that second visit, maybe the third visit, I can get a little more definitive. You know, I saw somebody today, the gastric emptying was normal. They actually had a pretty good electrical rhythm, but boy, was their gallbladder bad, you know, terrible gallbladder emptying, normal ultrasound. And so in my re-examination of the symptoms, you know, I said, you know, this was atypical. It wasn't textbook gallbladder, but man, that's the one test that was really bad. It's not the whole answer. And so you have to have that broader differential before you can get more definitive. And then you get more confident about, you know, what's driving the symptoms. That's how my brain has thought about it.
Yeah, thank you. That's great. I have a question, Dr. Koch, for you. I mean, when these patients present at the, you know, this first visit and you're doing this workup, the slide that you shared with the diet progression was fantastic. I could see that being very helpful. Are you giving patients advice at that time, despite not maybe having a definitive diagnosis, because they are coming so symptomatic? Is this advice you give right away, no matter what the diagnosis is? And do you ever refer to a dietitian, or do you have resources? Like, how are you like equipping patients with this information?
Yeah, that's a good question, because you know, I don't go into that diet unless I have pretty good evidence for delayed emptying, or nausea and vomiting is a problem. We might not have a delayed gastric emptying. You know, most of our patients have normal gastric emptying, but they still have those symptoms. And so a lot of people haven't had any dietary advice. We did the NIH study of diets and gastroparesis. As you know, they're really not eating healthy. Some healthy food makes them sick, and only 14% really were ever sent to a dietitian. It's terrible. I mean, diabetic gastroparesis, maybe 50-60% will see a nutritionist. And the answer is yes. I do. We do have that dietary person with an expertise in gastroparesis, and hopefully patients who are listening, you know, who think they would like more info on that can get that kind of referral. I think that there was a patient, you know, who I saw with gastroparesis, and when they came back, they were losing weight. So for most doctors, losing weight is a bad sign, right? Why are you losing weight? Well, she was losing weight because her nausea had gone away, her vomiting had gone away, and she had reintroduced salads. She thought she could eat healthy, and she wasn't dependent on, you know, mashed potatoes and crackers that were allowing her to survive. But as she began eating better, she actually losing weight. Welcome to the world of neurogastroenterology, you know? So it's complex, right? Because we have so many foods. I do warn them, this is not a complete diet. We will sneak in more fat later, but this is to get over those bad days.
Yeah, I think that's great. And I think that's a really important message to give to patients, because there isn't this one concrete list, right? Like every single person with gastroparesis can only eat this and never eat that. But absolutely, when there's nausea and vomiting, those very specific guidelines can be helpful. But there's so much nuance, right? Even like when you mentioned, oh, patients might not be able to tolerate dairy. It's like, is it dairy or is it lactose? Because there's a really big difference. So just trying to have as much options, I think that kind of ties back into the hope, you know, that Laura was talking about. Like people want to see like, oh, there is hope. I will be able to eat more than just these 5 things forever, because that's terrifying.
Yeah. Actually, you know, what's terrifying to me is to go to the grocery store. I get freaked out because there are so many choices. There are so many foods, most of them not healthy, that I say, you know, these are guidelines, and then based on how you feel this morning, noon, even based on how you feel, you choose what you, and you'll hate my one suggestion, Emily. Do you want to hear the one suggestion I make for folks who are really having trouble eating anything?
Absolutely.
I say, do you like jelly beans or do you like caramels? You know, who doesn't, right? I said,
Love
well,
it.
why don't you start with, 10 jelly beans a morning? We just want something to stay down. We'll take anything. And, sometimes it's just a few successes of a food, which you wouldn't want to live on jelly beans, but maybe you would. But the fact is, it gets some calories in, tastes good, stays down. That's a win.
And that goes back to that message of hope again that Laura was bringing up. And then I guess one of the audience members has a question about, when do you think about psychological interventions, and do you for patients with gastroparesis? Is that something that you incorporate into the treatment? I know we do that for IBS and functional dyspepsia and other functional GI issues.
Yeah, and Laura might comment on that, but I'll tell you, most of my patients, because of our tertiary network, I can't think of a patient who isn't on some kind of antidepressant, anti-anxiety. I bet 90% of my folks come in on something. Baha, maybe yours do also, and they say, yeah, this is helping my nerves a bit, and maybe but my depression. But Dr. Koch, I'm still nauseated. I'm still vomiting. So these are stressful symptoms, debilitating symptoms. The symptoms themselves are depressing when you can't eat like you used to. And this is something Laura might talk about, because so many patients have told me, I want my life back. And I didn't understand that for a long time. And, they're not being just crazy depressed. They want their life back because it was the life of social interaction, and it's around food. It's around the wonderful hospitality you can extend to somebody when they come to your house and they're going to enjoy food. And the patients can't do that. And they withdraw. Everybody in the house then becomes anxious. It's not just a one patient problem. It's the whole household. Now they don't know what they should do at dinner time. Now they're getting anxious, which is making the patient more anxious, and they withdraw. So, if you can get to the bottom of this is the joy of neurogastroenterology. If somebody comes back and they're better, you've changed their life. You've changed their life because there was no hope, there was no answer. And maybe Laura can talk about how psychologically distressing this was. And I don't even remember if you were, on something for depression, but from a patient's perspective.
Yeah, Laura, I have on the same question. You can definitely answer Ken's, and then also, when did you feel comfortable, if you did feel comfortable, and at what point to discuss missing work if you miss work, or you just more personal, I guess, things that you could bring up to Ken that he could then help you out with.
Right. And back to Dr. Koch, what Dr. Koch was saying about the psychological part. Our gut is the seat of our emotions, right? We all learned that, right? I just to be quite honest with you all, I lost my sister a year before all of this started happening, and immediately upon losing her, my appendix had to go. I mean, it's so obvious to me now that, yeah, gosh, my gut was just, her loss was felt in my gut and manifested in the operation of my gut. And that's not a bad thing now to understand, that your emotions are, how many expressions do we say? Oh, my gut feelings. Oh, this doesn't feel good in my gut. This is just wrecking my gut. And everything, all the expressions that we have are actually true, right? It's an expression of what you feel without knowing necessarily. but it is knowing. And yeah, that was devastation for me, her loss. And so back to like losing my livelihood, what I experienced the most, and I had the most wonderful mother, and she came because I was on Finnegan, because at that particular time, Zofran was not covered on my insurance for this problem. So at that point in 2005 dollars, it was $3,000 a month, which is crazy. Now it's different, I know. But so my mom, I was on Finnegan, and my sweet mama would come and drive me around to all the doctors that I needed to visit. And it's debilitating. What if I hadn't had my mom? I'm single. It doesn't matter, but you're always responsible for yourself. I could not have continued without my mom. My mom's not here now. So, we're all alone in these diagnoses. And man, something's got to change.
Well, thank you for sharing that with us. I think, a lot of times we feel as physicians that we cannot prod to ask about personal questions and things like that, but I think it does definitely bring us together.
Oh,
We all have common
please,
ground, physicians and patients.
please ask.
Yeah.
Please ask.
It sounds like,
'Cause-
you're saying that it's okay for us to ask as physicians.
Please do.
Okay.
I beg you.
That's
'Cause
important.
it is important. Thank you, Baha.
Yeah,
It
thanks
is
a lot.
important.
Okay, and I know Emily's gonna go next.
Yeah, so I can't believe it's already 6:56, right? We're at the end. Laura and Dr. Koch, thank you guys so much. Any final words that you wanted to share before we kind of close out the night?
Laura, do you have a comment?
I will continue my comment on how grateful I am that the patient perspective on this particular subject is being heard. I thank you so much. And there are so many people that suffer, and I follow them. And, we need, and including me, need to educate them on what's available. And Dr. Koch, I thank you, of course, as my physician, my gastroenterologist rock star, which everyone can be. And because you listened, and I thank you, and you're still listening.
Yeah, thank you, Laura. And I do think that these are tough. These neurogastroenterology problems are tough. They're tough symptoms across the board. They're not easy for the patient, and they're not easy for the doctor. So getting that rapport will help move down the line. Like Baha said, maybe sharing equal. Doctors get frustrated too. And we really get frustrated when we can't help. But the doc can't give up. We're supposed to press on, find the perpetrator, do tests, think open-minded, and keep saying you're going to follow it out. These can be chronic disorders. Accept it. They're not going to be over and done with in a visit or two. And so that's not easy in this age. And so but that's what we have. So I appreciate the ANMS for allowing us to talk tonight. And Baha and Emily, thank you very much for having us.
Yeah, thank you. And thanks to the audience for joining us. Have a
It's
good
been
evening.
pleasure. Thank you all.
Thank you.